Yeah.
and the heart herniated.
Yeah, it always does.
So, but that case, I don't know if that was a rupture of the
I don't think it was
pericardium, of the
something else.
myocardium.
Yeah.
There you go.
All right. So looks like I'm the one who's gonna be beaten up by the panelists today, huh? I, as I said, I don't know if I said this before, but one of the presenters had an issue, so he wasn't able to present the case today. So I'm gonna do it because I have like a case. It's been a while since this case was done, but since we don't have this discussion so often here in the meeting, I thought it was interesting just to grab some of the ideas and some tips and tricks, some of the pearls that you might offer for everyone who's joining either live or even joining us after this meeting is recorded and is available in the website. So everyone see my screen?
Yep.
All right,
Looks
perfect.
good.
Perfect. So, all right. So I'm gonna start this like it's 12 here in Miami. So I'm gonna start the case. As always, thank you very much for joining this presentation, this meeting that we do every Monday. I see that we have a lot of people here today and a lot of the panelists that usually join our meeting. So I think we can do it as usual. I'll just call everyone who's interested in providing some comments, questions, anything that you might be interested in discussing. It's not a lengthy case. It's going to be pretty straightforward. So I think we're going to have an interesting discussion here today. And I see again a lot of the panelists: Dr. Frisby, Dr. Untrak, Dr. Collet, Dr. Let me see who else is here. I saw Dr. Kasim, Dr. Hochman, who always provide their comments here. And we have a lot of other people, Dr. Epstein, Dr. Valenzuela, Nadel Vusiu. So a lot of people will be able to participate. And again, I'm gonna call some of you guys to provide some comments. But if anyone is in the meeting and wants to say anything, just write something in the chat so we can identify you, and then we can open your mic, and you will be able to provide comments as well. So let's start here. So this is a 23-year-old male patient. He was fall from 8 meters height, and he was basically assessed at the scene by the EMS and brought into the hospital. The transport time, as you see already, it's pretty extensive. It's like 2 hours from the arrival to the scene. From EMS taking him to the hospital, it was 2 hours. So it's a lot of a very fair amount of time. And the only vital signs that we have from the scene are basically the heart rate, which was 130 BPM, and a GCS of 9 at the scene. And the EMS told us that there was some blood in the airways, and the patient had altered level of consciousness with a GCS of 9. They elected to do a pre-hospital intubation before transporting him to the hospital. When this patient arrived at the hospital, he had a secured airway. He got the ET tube. His his breath sounds were diminished on the right. He was saturating 91%. When we go to C, D, and E, he had the heart rate of 130. His BP was 7/40. He was pale. He was cold skin, weak distal pulses. His GCS was 3T. He was intubated and sedated, normal pupils. And he also had thoracoabdominal abrasions and a thigh deformity on the left side, which was kind of immobilized from the EMS. Not any fancy devices, but just a couple of wraps to try to immobilize this deformity. And the suspicion was a femur fracture on the left side. He also got a ABG when he got into the hospital. His pH was 712. His base excess was -12, and his hematocrit was 34 at this time. So basically, this patient got a fast exam, and this is the fast. I only have the right upper quadrant, so we can see the liver here. The kidney was showing up. This is the gallbladder, and we can see a pocket of fluid here around the liver, like just below the liver, between the liver and the kidney in the Morrison's pouch. So we can see this anechoic image representing the free fluid in the abdomen. And this patient also got, as part of the EFAST, he got a thoracic ultrasound. And on the right, we were able to see this image that basically confirms the suspicion of a pneumothorax. So I don't know if everyone is used to interpret the images of thoracic ultrasounds. So what we see here is basically skin, the subcutaneous tissue and muscles. This white line is the pleural line, and we basically are looking for pleural sliding. There is pleural sliding on the right side of the screen of the image, but there is no pleural sliding on the left side of this video. And when we find this image, basically the transition between a pleura that is sliding and the pleura that is not sliding, this is called lung point, and it's virtually 100% diagnostic of a pneumothorax. So that's why we confirmed the pneumothorax using the ultrasound in this case. Also, before I open for a couple of questions and discussions, we got a pelvic X-ray. But before the pelvic X-ray, this is the physical exam that we found in this patient. So you can see that there was, even without this improvised kind of device to try to stabilize the pelvis, there was still a wide gap in the pubic symphysis that is really associated with this X-ray that we got in the trauma bay. So I wanted to ask the first question for this case, and I'm going to go over all the panelists to get their inputs. But I wanted to know, in a case like this, so we have this patient, blunt trauma, high energy trauma. He's hemodynamically abnormal, so he's hypotensive. He's tachycardic. He has an open pelvic fracture, open book pelvic fracture. He also has a pneumothorax on the right side and a potentially open femur fracture on the left. So in this situation, what would be the optimal initial management? So let's assume that we have all this information when we're going to start to do something about it right at this moment. So let's start with Dr. Frisby. What would be your approach here, Dr. Frisby?
Well, let's see. I think I'd put another chest tube in on the contralateral side, just based on what Maddox taught me. And I think most probably I would use a pelvic binder to see if I couldn't decrease that open book. Obviously, the pelvic fracture needs to be stabilized, but you're going to lose a lot of fluid, a lot of blood into that fracture. You can lose three or four units into it. So that may be where most of the problem is coming from, although I strongly suspect he's really pouring from the pelvis. That's a really wide open book. So if you can decrease that, you might be able to stop some of the venous flow. That's the first thing I would do. There has to be some thought given to later on getting an evaluation of his head, but since we don't know how he landed, apparently he must have landed on his right side or left side, but I can't tell you that now. But that's the first thing I would think about doing.
Perfect. Dr. Untracht, anything else? Any other ideas?
Well, I would assume, based on what you've shown, that this happened in Brazil, not in Miami, and that he did not get a blood transfusion along the way, probably no fluid or not much fluid, if any at all. So what I would and 2 hours, a 2-hour transfer, a patient arrives alive is actually a decent sign. So I agree with Dr. Frisbee. First thing is airway breathing. So I put a chest tube on the right side. The left side, if he had sliding, I would leave that for now. And then circulation, I would initiate the rapid transfusion protocol. If it's in Brazil, just get some blood available and transfuse. Then try to close the open book, and then you need to do something to stop the bleeding. And if this is in Brazil, there's no I don't know anyone that has Reboa there, but if this were in Miami and he came with those vital signs from an open book pelvic fracture, I would put a Reboa in on the right side, away from the open wound, and see the effect of that, and then proceed to the operating room to take care of the fracture. Also, I agree with Dr. Frisbee, he probably fell on the left side, not his on one or both feet, because he would the pattern of the fracture would be different.
Perfect. Dr. Collet, any comments, anything different?
Carlos, I want to ask a question. Is it injuries in the pelvic, on the perineum, or not? Because when we see you have this blood on the back, so I think there's something different. You can have an open, unstable open pelvic trauma, but it's an open pelvic injury, and this you have some blood comes from the pelvic injuries, from the pelvis or the perineum. So it's very important to do, because it's at the moment I read all the comments, maybe try to put a chest tube, initiation transfusion, blood transfusion, and then I need to know there is blending from the pelvis for the perineum, because if I go to start to make a tamponade of the perineum injury, and then go to a DOR to make a pelvic perineal packing, and then open the laparotomy. I think that's the way that I do here in Brazil. So if the patient may become sometimes more stable, some people here want to make a angio-CT. But in this situation, patient is unstable. You have open pelvic fracture. You have probably a pelvic perineal injury. You can't go to stop bleeding. So I think to stop bleeding in this case is go to the tamponade of the injury of the perineum, go to the pelvis, tamponade the pelvis, prepacking, and then open a laparotomy and try to control the hemorrhage, the peritoneal hemorrhage.
All right, perfect. Yeah, we're going to talk about it as well. Dr. Kassim, any other thoughts on this one?
Well, my thoughts are a little bit different from all the previous speakers, because I am facing a patient who has chest injury, abdominal injury, pelvic injury, and fracture of the hip, or fracture of the femur, whatever it is. Now, what is the thing that concerns me the most, that the patient may die while I'm attending to him, would be bleeding. And also, I would be cognizant of the fact that I cannot put positive pressure ventilation on him when he's got pneumothorax. So, like Dr. Frisbee says, I would deploy chest tubes immediately, put a Foley catheter in immediately as well, and then I have to make up my mind what I'm going to do to stop the bleed in the pelvic cavity. Yes, I would put a pelvic binder and see if I can reduce the cavity somehow to contain the bleeding, but I don't think that is going to help me to control the bleeding very much. So I have to make up my mind. What is the first thing that I would like to do to this patient to stop him from bleeding to death? So what comes to my mind is more than likely that he's going to bleed from venous side of the pelvic cavity, like Dr. Frisby and Dr. Untrak have said. So I will go for where I can get the best result that I can. In a place like Miami and other big institutions, I'm pretty sure they will deploy the Riboa immediately and get control of the infrarenal abdominal aorta and cut off the blood supply to the pelvis. But 90% of the hospitals in the world don't have Riboa and they cannot deploy that. So what is the next best thing that I can do? I think I would take him to the operating room, having put a chest tube in, Foley catheter in, transfusion in place. I would do a midline incision, but I would not enter the abdominal cavity immediately. I think I would do retroperitoneal dissection in the pelvis and see if I can get rolls of sponges to pack it in, to pack off the pelvic vessels and see if I can get some hemostasis there. And then I will probably look into the abdominal cavity. That is the sequence of things that I would be doing. Thank you.
All right. Thanks a lot, Dr. Kasim. I'm going to move forward because we have a couple of other interesting things to discuss. And we also have a lot of other panelists that might be able to discuss this further. I'm just going to share the results of this poll that I placed. So I was asking Riboa yes or no. And the idea was to see what the participants would do in this case, right? So there's one response to place the Riboa in the ED or trauma bay, more responses of no Riboa in this case, and yes, but only after pelvic packing, also just one response. And I'm gonna place another poll in just a second. So I got a message here in the chat from Dr. Judy Lay, so saying that in USC they do exploratory laparotomy and iliac vascular loop and ligation, packing and open abdomen. So I think she's talking about addressing the pelvic bleeding and also with an exploratory laparotomy, trying to figure out if there's a source, intraperitoneal source of bleeding as well. And Dr. Marcelo Oliveira just text as well, saying that the main objective for this situation is just stop the bleeding, do whatever you can to get the bleeding under control. And that's basically the idea. So the question here was the initial management for these patients. So basically, to summarize what the panelists said, so basically chest tube for the pneumothorax. There is a concern of maybe having a small pneumothorax on the left side. So some also would put a left-sided chest tube and basically start doing also some volume resuscitation. So, Dr. Hochman, do you have additional comments here for this situation? Just send me a text. I don't know if.
Yeah, sorry. Yeah, I will do this will be the same, but with a few things differently. One is this patient is hemodynamically unstable. You have a positive FAST and you have a pelvic fracture. So statistically, 70% of those cases, the bleeding will originate in the abdomen because of the hemodynamic instability, and 30% in the pelvis. So those cases, either the bleeding in the pelvis and some minor bleeding in the abdomen, or the retroperitoneum is open. So when that happens, the bleeding from the pelvis is going to the intra-abdominal cavity. So in those cases, the extraperitoneal bleed packing, it will not really help you. So bottom line is that I think a patient like this has a pneumothorax. He traveled 2 hours. He will travel maybe 5 minutes to get to the OR, and I will put the chest tubes in the OR, probably bilateral chest tube. I will probably put a real abdominal binder, because in that picture, that abdominal binder was really not in the right position. So this doesn't appear. Maybe, I don't know, it's a very weird abdominal binder, but doesn't appear to be centered in the trochanters. So I would probably reapply the abdominal binder, see how much that helped me, and proceed with an exploratory laparotomy, because I have 70% chance that the bleeding originated in the abdomen rather than in the pelvis. If the bleeding is in the pelvis and is bleeding into the abdomen because the retroperitoneum has a hole, I will do something that I haven't found described in the literature, but I've done many times with success, is I will make the hole in the retroperitoneum bigger. People say, oh, you are going to lose the tamponade. You already lost the tamponade. It's bleeding through those holes in the retroperitoneum. So I extend incision lateral to the bladder and the rectum and pack it that way. And the packing is not contained by the peritoneum. The packing is effective because of the bones. It's like when we pack the liver, we pack between the liver and the rib cage. This is the same thing. We need to pack between the bony pelvis as much as we can. Hopefully by now with the abdominal binder is more effective. I will pack it that way. If there is no bleeding inside the abdomen, well, I can try in that case to do an extraperitoneal packing. But if the bleeding is inside the abdomen, so you already lost the tamponade from the peritoneum, now we go through the peritoneal cavity. And two more things. We did a review of the literature on Riboa, and we tried to publish as guidelines for ease, and they were rejected with horrible comments from one of the reviewers. And the main reason, but the reality is that there is no literature to support the use of Riboa in these cases. It's all anecdotal literature. There are a few cases when you have prolonged transport time, obstetric hemorrhage, those cases you preempt it, but otherwise really doesn't appear to do too much. There are other things that you can do. You are in the OR, you can open and cross clamp the aorta, or like it was mentioned in the comments, the internal iliacs, put vessel loops around the internal iliacs, so you give the radiology the chance to go and embolize later. But if I were to put a Riboa, I would put it from the left side, which is the injured side. So you leave the radiologist the access to embolize from the right side. Because if you put the Riboa on the right, you are limiting the possibility of the radiologist to embolize the injuries on the left, which appear to be the source of the bleeding. And finally, and this is unusual, but I will disagree with Dr. Kasim, I will not put a Foley in this patient because might have a urethral injury. I will try to rule out that. And I always say that nobody dies for lack of Foley in the trauma bay. Yes, you need to make sure that there is not a bladder injury. You will need to check for hematuria and everything. But I will be reluctant to put a Foley early on this patient. But that's me. But that's one of the few things I will disagree with Dr. Kasim ever.
That's interesting. I was gonna say that, and I'm already happy with this case because I got some controversial comments here. So it's interesting, and it kind of illustrates the how these decisions are done, like in the moment when you are looking at the patient, you are assessing the patient, and some things might be a little bit different from the panel from a panelist to another. But basically, we are converging to the same point of trying to get this patient, trying to control the bleeding as soon as possible, trying to get this patient adequately resuscitated, and maybe getting him to the OR to do all of these. Because remember, we have a positive fast, we have a open book pelvic fracture, and a hemodynamically unstable patient. And as you said, Dr. Hoffman, that binder, the thing that was in the pelvis, was basically something that the EMS used to transport the patient, but it wasn't a binder really. In this case, in particular, there was no binder in the hospital in the trauma base. So when that happens in that institution, we use a sheet to try to close the pelvic fracture, and that was one of the things that we did for this case. So basically, as you all of you said, the initial management was basically volume resuscitation, chest tube, placing a binder, and trying to close the pelvis with the sheet, and expediting this patient as soon as possible to the OR. We didn't do any CT scan for this patient. Obviously, he wasn't in a good shape to undergo the CT scan, and basically that's what we did. So I did this poll before about the Reboa. So I saw that some of you would place a Reboa, some of you wouldn't. And that's just a reminder of how to position the Reboa, the zones that you can place. And for this patient, probably would be if indicated, would be placing this zone 3 Reboa for this situation in particular. So this patient was taken to the OR, and I got briefly a couple of comments addressing this, especially coming from Dr. Cassin and Dr. Hochman. But I do want to maybe touch on this subject again with the other panelists as well, because in this situation we have two obvious I mean, not obvious sources of bleeding, but we have two cavities that might be bleeding, and we need to address them as soon as possible. It would be ideally to do it simultaneously, but it's very hard to do it. So basically, you have to figure out if you're going to go to the abdomen first or to the pelvis first. And I know that this might be a controversial topic, so that's why I wanted to get the input from all the panelists. So from one side, you have the abdomen, that you can have a massive intraperitoneal hemorrhage. You have a positive FAST. There might be some sources of bleeding inside the peritoneal cavity. You will be addressing also these stigmas of thoracoabdominal abrasions and the FAST that was positive. And on the other hand, you have the pelvis. There's a deformity, an open book fracture. We know that this is a space that can get a lot of blood. You can pour almost the whole volume of blood inside the pelvic cavity. And maybe you should address this with mechanically, trying to get this a little bit better. So we briefly talked about it. So I'm going to ask for the other panelists to talk about the situation, how to prioritize, because I'm thinking that this is a fairly common situation where you get the positive FAST and the pelvic fracture. How do you address this? How do you assess which cavity you should go first? Is this something that is basically straightforward every time you go to one or to the other, or do you use some clinical findings or some imaging, anything to make this decision? So let's start with Dr. Untracht about this topic.
Yeah, so the protocols are pretty straightforward when you evaluate these patients with pelvic fractures. You assess the peritoneal cavity, and if it's positive, then the patient needs a laparotomy. You go there first, and as Dr. Hochman said, 70% of those patients will have a bleeding source in the abdomen, in the peritoneal cavity. So in this case, I would do what pretty much everyone else said. You try to reduce the open book fracture, because this is open book. You can accomplish a lot with a sheet or a binder. Just reduce the fracture, and then start with a laparotomy, evaluate, and then you'll see right away if there's a big retroperitoneal hematoma in the pelvis. That's likely the source if you don't find anything else in the peritoneal cavity. But he does have blood in the peritoneal cavity, so I think you need to go there first. The one advantage of using the Reboa is that you can insert it initially. In this case, because he is so hypotensive and tachycardic, I would insert it because of the positive FAST. I would insert in zone 1 initially, see the effect of that, and if he has a good response, then is likely, if it's from the pelvis, likely arterial. And then you'll see right away, once you open the abdomen, if you find the source of bleeding there, get control of it, then you can move the Reboa down to zone 3, and then try and let the balloon down if there's no retroperitoneal hematoma, and see how he does, and that'll judge what you do next. If he does get hypotensive again, you can reinflate it and then go with an open abdomen, just cover the incision, go to IR, and see if you can deal with it that way to avoid ligating both hypogastric arteries because of the symptoms that would occur with that post-op.
Perfect. Dr. Collet, do you agree with that? Do you do anything different? What's your take on this?
Usually here, I think it's very easy for me to be a preperitoneal packing. I maintain the sheet on the pelvis here because I don't have a binding, and I open quickly the extraperitoneal and put 3 or 4 pads on the left and the right, close and start open up the abdomen. If I know, if you have seen very, very much fluid in the abdomen, I will start for the abdomen. But you have only positive fast, I start with the pelvis and then open the abdomen. That's the way.
All right. So basically, you would use the amount of fluid or the number of views that we have in the fast with fluid to make the decision if it's either starting the abdomen or the pelvis. And if you do the pelvic tamponade, would you open the binder, do the pelvic tamponade first?
No, I don't open the binder. I open the incision or pharyngeal midline incision. Only don't open the extraperitoneal. Don't make communication of the extraperitoneal cavity for the peritoneal cavity. Tamponate the pelvis and then close it and open in another incision, not a continuous incision, or another incision, and see what's happening in the abdomen.
Perfect. What about you, Dr. Frisby? Would you start by doing like extraperitoneal pelvic packing, or would you go first with the laparotomy?
Well, first of all, let's go back. He was 2 hours in transit. Having been to Brazil, I can tell you with the traffic there, that's pretty normal. And yet after 2 hours, he still has a blood pressure with all of this injury. This is most probably, the major portion of this is venous. And with that dramatic pelvic X-ray, I think it would scare everybody not to do something about that. So I would put the binder on and leave it there. If I was concerned at all that this didn't do anything, I would open the abdomen. But I'm not sure I want to do anything other than the binder. And as Collet said, I might want to make that phalansteal incision and open just down to the peritoneum and pack it full of wet laps if I could get them there. That's what I would do.
Perfect. Yeah, and we heard from Dr. Cassin and Dr. Hochman about this, the approach that they would do. So, Dr. Cassin.
Well, the question you are asking was quite clearly answered by the group in Denver, Dr. Moore et al. And they approached problems like this very clearly. What they did was what Dr. Frisby has mentioned. They would open the pelvis first because that is where the patient is going to exsanguinate and die from hemorrhage. We often see blood under the liver in abdominal trauma, in a liver injury, for example. We try to treat it with conservatively initially. Nobody rushes into operating on that patient because they saw some blood under the diaphragm over the kidney. And I think the amount of blood in the abdominal cavity can be large, but also it can be very small. But for sure, with a pelvic injury of this magnitude, this patient is more likely to die from hemorrhage from the pelvic venous injury as opposed to arterial. And I think it behooves for you to go there first. Now, regarding the need for Foley catheter, I could argue with Dr. Hoffman, but I think when you have significant pelvic injury, there are three things that can be injured: the bladder, the ureter, the kidney, and the arterial and venous system in the pelvis. So by inserting the Foley catheter, you're just eliminating one.
All right, perfect. Yeah, interesting. So I did this poll exactly because of this topic and this discussion, and we can see that there's a 50-50 choice between pelvis or abdomen, and the panelists were very clear in talking about the different approaches and why they choose one over the other. So I think this was really interesting. So in this case specifically, the plan was the decision was made to do to put the pelvic binder, take this patient to the OR, start by a laparotomy and not by a pelvic, extraperitoneal pelvic packing. And the team found approximately 500 cc's of blood in the upper quadrants. There was a grade 2 injury to the liver, and also the segment 2 had a little bit of active bleeding, nothing that would be very, very massive, but it was active. Other than the segments 3 and 6, that there was no active bleeding whatsoever. They saw this zone 3 retroperitoneal hematoma, and basically what they did was control the bleeding real quick with liver packing, and leave this abdomen open and start working at the pelvic cavity. So as some of the panelists said, sometimes you get to the abdomen and basically you don't have you don't have a lot of bleeding inside the abdomen, and basically you need to address the pelvic area afterwards. Or if you do on the opposite side, if you start by the pelvic, if you open later the abdominal cavity, sometimes you only see bleeding. There is sometimes also that you get the intraperitoneal bleeding, but there's nothing actually bleeding inside the peritoneum. As Dr. Hoffman was saying, some of the fluid and some of the blood can actually come from the retroperitoneal space and basically go to the intraperitoneal, decompress into the intraperitoneal cavity. So this was the approach that was done for the pelvic for the extraperitoneal pelvic packing. This is a video. It's kind of a little bit speeded up as just for this meeting purposes, but basically showing how this was done. So it was a midline incision, as Dr. Collet was saying. The incision, abdominal incision, was over the umbilicus. It was covered already, and you can see there's blood coming from the pelvic area, and basically the surgeons are getting all the instruments and getting lap pads to start packing. As in most of these situations, the pelvic hematoma has already dissected the space for the surgeon. So it's basically, you don't have to do a lot of dissection. You just have to pack both sides. And if you are able to do it, putting some packs in the smaller pelvic area, as Dr. Hoffman also said, trying to put in the bony area, and you'll see that they're rolling the packs, they're putting the packs to go around and go to the posterior aspect, going right over the psoas muscle, and trying to get this packing on both sides. And I think the video just shows one side on the pelvis, and also they're going a little bit downward on the bony pelvic area to make sure that everything is pretty much packed as well. So I wanted to go over with the panelists to get some tips and tricks about this pelvic packing. So Dr. Untracht, would you tell us do you have any pearls for anyone who's doing these procedures, anything that someone cannot forget to do it, or there's a specific way to do some of these procedures, anything that you might add to us?
Well, it looked like exactly what you did. A lower midline incision, stay out of the peritoneum, and 3 or 4 packs on each side. And the hematoma, if there's a big hematoma, I would try to scoop it out and then put the packs in, just like you showed. And really that's all there is to it. But if this is that patient, where's the incision from the laparotomy that you did first? Was it out of the upper abdomen, or where?
Yeah, it was only on the upper abdomen, and they covered the like they put some lap pads over the incision, and they covered with another sterile field. So we were in this video we can only see the lower part.
Okay, and they were able to see well enough. So that basically that corroborates what Dr. Qasim said, and also Dr. Collet, I believe. So but I think either way is okay. You can handle it either way, but their judgment was spot on this case.
Perfect. Perfect. And so Dr. Marcelo Oliveira is asking on the group chat, if you started the approach in the pelvic area after packing, and would you do a second incision to do the laparotomy? So that's something that Dr. Collet also commented on. So basically, he suggested to use 2 different incisions, because one incision, the lower part, you would use for the pelvic packing, and then the upper incision, the midline incision above the umbilicus, you would use to actually enter the peritoneal cavity. So it's basically 2 different incisions, and you have the umbilicus in between them to keep the peritoneal, the extraperitoneal area kind of isolated from the first one. Dr. Kasim?
Well, the group in Denver taught me how to do this properly. And what they do is they evaluate the patient initially, and they come to a conclusion what they are going to do, plan A, plan B. So if they're going to approach the pelvis, they do not do a midline incision. They do a fan and steel incision or transverse incision, where they go on top of the peritoneum and they dissect retroperitoneal on top of the peritoneum and also lift the bladder up and get a good space there. Then they take the lap pad and make it into a round lap pad, like a big cigarette, they call it. And then they pack those on the side, 3 on each side and 1 behind the pubic symphysis. And that's the way they described it. And I have done that once, and it seems to work in my hand. Then they go after it. If there is an abdominal problem they suspect, then they do a midline incision above the umbilicus and have a look at it. Then following that, they send the patient to IR to see if they miss any bleeding areas. That's how they do it, and that's how I did it once.
Yeah, interesting. Yeah, I'm gonna go over the rest of the case because we have one more topic to discuss. But basically, what we did in this case was the
There you
procedure.
are, yeah.
Yeah, the pelvic tamponade, the laparotomy that I was just telling you guys about. The ortho team also did external fixation of the pelvis and the left femur, which had a fracture. This patient, he wasn't really getting better with the 2 interventions. So there was a concern. Maybe there was still some bleeding, ongoing bleeding. By this time, he was still getting volume. He's still getting the blood transfusion, and there was a concern about either having a situation that you need to address surgically, or maybe doing this as an arteriography. So by this time, the team was considering, should we open the belly again? Did we miss something? Should we repeat the EFAST with the open belly? Should we do a repacking of the extraperitoneal pelvic cavity? Or should we take this patient to angiography or get the team up in the OR to do the angiography? So basically what we did, the team decided to call the vascular surgery or the radiology team. I'm not sure which one went upstairs to do this procedure, but basically this is what they found. Shooting the angiogram, we can see, especially on this image, you will see a kind of a blush on the superior, on the left side, the superior gluteal artery, and you can see also on this image the same blush on this left side artery. So the plan was then to embolize this. They were able to do a selective embolization of this bleeding, and by this endovascular procedure. So the patient got better. He went to the ICU. Eventually, he got his fascia closed after 36 hours of the procedure. He did have a pneumonia on the 6th postoperative day, got antibiotics. On the 10th, he was extubated, successfully extubated. And by 2 weeks post-op, he was discharged. Actually, he was transferred to the Orthopedic Institute to get a definitive treatment with orthopedics. In this hospital, in this institution, the two places are different, so they're different buildings. So they basically transition from one to another to get definitive repair once the patient is completely cleared for non-orthopedic injuries. So just to summarize this discussion, and I don't want to go past 1 p.m. here with you guys. I brought two studies and two algorithms or two practice guidelines that we have published. This is from Western Trauma Association for managing these pelvic fractures with hemodynamic instability. Basically, one of the most interesting figures that they have in this article is this diagram, this flow chart. And what I wanted to address here is basically that discussion of you having a positive FAST in a patient who is hemodynamically unstable. So you have basically the options to do a REBOA or doing the preperitoneal pelvic packing, considering the external fixation, and the option of doing an exploratory laparotomy and external fixation. And when you look at the WTA algorithm, they do suggest that you start by exploratory laparotomy and then consider the preperitoneal pelvic packing, also with or without angiogram and embolization. And one of the things that the literature discuss is exactly one of the point that Dr. Kassim just raised. So, would you take this patient to the angio after pelvic packing? As he said in Denver, he was talking about he learned the way to do the pelvic packing and then taking this patient to angio. And I know that in some centers this is not a straightforward decision. So basically, you try to figure out which patient needs the angiography and which patient doesn't need to go to the angiography suite. So one of the things that I got from this other article from the East, which is a systematic review and a practice management guidelines for pelvic fracture with hemorrhage. And basically, I got all the level 1 and 2 recommendations about this. So basically, they say that patients with pelvic fracture and who are unstable or have signs of ongoing bleeding, you should consider, of course, pelvic angiography or pelvic embolization. So this is a patient, in this case, that would be considered for the angiography. And again, you might take this patient to the angiography or take the team to do angiography in the OR before doing the pelvic packing. This is kind of also a controversial topic, and not all centers do it the same way. Also, you have another level 1 recommendation, which is patients with evidence of arterial intravenous contrast extravasation. They go to angiography regardless of a hemodynamic status. In this situation that I presented, we weren't able to do it because the patient wasn't stable. But if you get a CTA of the pelvis, for example, in a patient, and you have pseudoaneurysm, or you have contrast extravasation, as they're saying here in this article, then you should definitely get angiography and get this embolized. And when you look at the level 2 recommendations, we're talking about patients with pelvic fracture who undergone pelvic angiography and have signs of ongoing bleeding. And sometimes these patients should be considered for repeat angiography and maybe bilateral embolization as a empiric maneuver. And also considering this for patients who are older than 60 years with major pelvic fractures. So these patients should also be considered for pelvic angiography without any concerns about hemodynamic status. So either stable or unstable, these patients which are older than 60 years old and have severe pelvic fractures, these also might be considered for an angiography. And that's everything that I have for you today. And I want to get all the comments now from the panelists and final comments from everyone about this case, and hopefully we can continue the discussion for a couple of minutes. Dr. Untracht, anything to add for this case? Any other tips, tricks, anything?
Yes, I'll just add that the algorithm that you showed from the first article seemed to suggest, from the portion that we could see, that unstable patient does not go to angiography, only for stable patients with those kinds of pelvic fractures. So that conflicts with the second article. But in this case, if this, assuming this was in Brazil, if they don't have REBOA, if they don't have ready access to angiography, based on the findings that you showed, it looked like there was a primary dissection of the hematoma up along the left side. So in this case, and especially if it looked like arterial blood, one option would be to do everything that you did, put the packing in, but pack just the left hypogastric or ligate the left hypogastric artery, or at least put a tourniquet around it, a double vessel loop, to see if that controls. If you do have angiography, then I would be more likely to put a double vessel loop, tighten it, and then take the patient afterwards to angiography to see if that's where the source of the bleeding is. That's another way to handle it, depending on what your resources are. But very well done. It's still a difficult case, but I think it was a good sign that he got to the hospital after 2 hours. So you were able to get him taken care of and take him to angio despite him being hemodynamically unstable. So very, very good case.
Perfect. Great. Dr. Kasim, any final comments, anything?
I think you summarized the thoughts and feeling of the big whales in surgery, how you should manage this. I think there is an old saying, it says, it is better to be good than lucky, but sometimes it is better that you're lucky than good. And in this case, I think it is better to be good than lucky. And surgery is an art. And what some paper says may not borne out to be true in your experience. And I think it is kind of the gut feeling that you have when you see a patient and then you wonder, should I go into cavity A or cavity B first? And there is no full proof that one decision is better than the other. But I think you have to make a decision while you are there looking at the patient from all the data that has been presented to you. And in a case like this, you just have to make a good decision and hope for the best so that you don't get criticized on Monday morning grand round. Excellent case. You have summarized the management very well. And what the young surgeons should learn from this case is that you need to have a plan in your mind, and that will be plan A and plan B, and execute it, without any doubt, and hope for the best. And I think this is a good educational case and worth getting up on Monday morning at 9 o'clock Oregon time. Thank you.
Perfect. Before I move to the other panelists, I just want to emphasize that Kevin just placed the CME link, so you all can claim your CME for this meeting. So you will see the CME link on the chat that Kevin just placed. So feel free to get it. Dr. Collet, any final comments for this case?
Carlos, I think this case is very interesting because you have blending for two or more cavities and can decide what to do first. It's a great decision on the surgeon to do what to do first. I think in this case, I agree that we need to start with the pelvis and then with the abdomen. But if you don't have angio, you don't have regoa, you can approach you tamponate, then you can go to approach to hypogastric artery can be tied and embolization, surgical embolization of the hypogastric arteries. You can do is on the lateral incision on the abdomen, and then you can dissect the artery. You can find the hypogastric artery, and then you can embolization. Avoid to open the hematoma because it's high in the pelvis, and then you can put the section of the hypogastric artery, put a gel fan into the gel, tie it, and inject the gel fan in the artery, and then you can embolization in surgery like this. Sometimes it's very helpful to know how to do this, and I think it's very important. If you have angio, you can go to the angio, no problem. You tamponate it, continue bleeding, you can go to the angio. That's the way. I think it's very important. The important is how to think, what I have to fix first. The abdomen, the pelvis, the femur, what to do to fix up first. Thank you. Congratulations for the presentation.
Perfect. Thanks a lot. Dr. Frisby, any final comments before I move with Dr. Hoffman?
Sure. A couple of things. How old was it? 23? Was the patient 23 years old?
Yeah.
That's the reason he made it to the hospital. There you go. After 2 hours in the ambulance, he made it to the hospital based on how much energy he had left in the tank. I think if this patient had been, as the recommendations say, over the age of 60, we wouldn't be having a case. I don't think he would have made it to the hospital after 2 hours. So I thoroughly agree. You get somebody over 60 in this situation, I think you're probably going to have to call the angio people, post haste. But you did a great job. It was a really good case. I appreciate all the learning points. And anytime I can aggravate you, let me know.
Perfect. Thanks. Dr. Hoffman, you are the one that's going to provide the final comments and close this meeting.
Oh, shoot. Okay. First, I will make a comment. Embolization after 60 with both hypogastric, I would say those authors should be shot. And if I am the patient, I'd rather die than deal with the consequences of the bilateral embolization of the hypogastric, but that's me. Anyway, so a more serious tone now. Well, no, that's serious, okay? Don't embolize me, okay? Let me die. And a more serious tone, the incision. So we have here a confounding factor that you have injuries in many cavities. But if we were to limit this to the pelvis, which is what this patient ended up having, the approach is first to adjust the binder, because many times that will give you control because it's venous bleed. And if that doesn't give you control, so it gives you control, the next step is to go to angio. It doesn't give you control, you need to go to the OR and you need to pack. And you shouldn't remove the binder, you should try to work around the binder to do the packing. If the patient you need to go to the OR because it's unstable or the IR will take too long to be set up, if you have the possibility of doing it in a hybrid room, that will be ideal because they can embolize. Maybe you can address whatever is going on in the abdomen. Regarding the ligation or passing vessel loops around the internal iliacs, it's easier said than done. They are kind of difficult to do because you have a huge hematoma there. So you can identify the iliacs easier, but you cannot identify the ureter or the iliac vein easily. So doing this, you might injure the internal, the iliac veins or the ureter. So one thing that I found it works is try to find something outside the pelvis where I can identify the iliac, probably the common iliac easier, and follow that down rather than jumping into the hematoma, which is very difficult to work in that hematoma. And I don't want to, the iliac veins are very, I'm not worried about an iliac artery vein, I'm worried about an iliac vein because those are really difficult to control and they bleed a lot. So finally, if we will do a pelvic packing, I prefer to do a vertical incision. First of all, the fan steel incision, the classical fan steel, is a horizontal, is for OB procedures or GYN procedures. It's an horizontal skin incision and a vertical incision in the midline, which takes time. So otherwise, it's a transverse incision. The reason I prefer a vertical incision because it's not unusual that these patients, after everything is said and done, they will need to have an open abdomen because they have other injuries. So having a T is kind of like, it leads to more problems. So personally, I prefer to always do a vertical incision and extraperitoneal, not to do a transverse incision, but that's a personal choice. And you already mentioned that the packing is done with the bony pelvis. So you need to reduce the volume of the pelvis to the packing to be effective before the patient goes to IR. But those are the only comments I have. I think that you did everything by the book and the results showed that the patient did very, very well. One final comment trying to put everything together. Many people mention here, no, I will do this, I will do that. And that is usually based on experience. And people say, oh, I saw this patient and I had the feeling, I had a gut feeling that I needed to go to the pelvis or to the abdomen first. That's not a gut feeling. That's is been studied is a pattern recognition of a surgeon who has seen hundreds, sometimes thousands of similar cases. So that's very valuable. And so is somebody that Dr. Collet or Dr. Cassini or Dr. Untrack say, oh, no, I will go there first. Well, that has to be taken very seriously because that is experience talking and it's a pattern recognition, which is very, very valuable. For the junior faculty here, residents, yes, you have to follow the algorithm. And you will see many times the more senior people do not follow that algorithm. But they don't follow that algorithm because they are capricious, but it's because they have experience that took years to build in order to approach the injury in a more effective way. So that's kind of like, maybe that's the reason that we are all talking a little bit about this pattern recognition. And that's the reason that what we say appears to be so different. But none of us was really in front of the patient like you were. So that's all I have. Sorry.
Yeah, that's perfect. All right. So thank you, everyone. We're just 5 minutes more than I was expecting to do it, but I think the discussion was great. So it justifies this 5 minutes because it was really interesting. So hopefully I'll see you all in the next Monday. We're gonna have another case, and just remember that Kevin posted the CME link so you can claim your CME credits for this meeting. It's on the chat. Feel free to claim it for yourselves. And I hope to see you all next Monday. Thanks a lot for being here today, and also to all the panelists. Thank you for being available to provide your comments, and it always enriches the discussion, and we always learn new stuff in these meetings. All right, thank you very much. See you next Monday.
Carlos. I'll see you Monday.
Thank you.
Bye-bye.
Bye-bye.